Hello, good morning. I am Professor Ibn Auf from the Faculty of Medicine and Health Sciences, Umdurman Islamic University. This is my fourth lecture on wound and gangrene. And in this lecture, I am going to talk about skin ulcers. And the objectives of this lecture is that the students will be able to define what is ulcer and its difference from wound and the common signs of ulcers and the differences between basal cell carcinoma and squamous cell carcinoma and melanoma. Now the difference between wound and ulcer. Wound is breakdown of epithelium inflicted by trauma, while ulcer is a spontaneous breakdown of epithelium not related to trauma. Now, the common signs of ulcers. In the face, we find ulcers in the sun-exposed areas, like squamous cell carcinoma, basal cell carcinoma, and malignant melanoma. In the tibia, commonly we find traumatic ulcers. However, in the medial malleolus, we may find venous ulcer, while in the lateral malleolus, we can find arterial ulcers. At the tip of the toes, usually we find neuropathic ulcers and ischemic ulcers. However, below the nail, we can find acral melanoma. In the sole of the foot, we find trauma causing wounds and diabetic septic wounds and malignant melanoma, and also probably the foot ulcers of mycetoma. In the genitalia also we find syphilitic ulcers. Now, to properly describe the ulcer, we have to speak about the margin, edge, floor, base, and draining lymph nodes. And by the margin, we mean the circumference contour of the ulcer, whether it is rounded or irregular. However, if it is rectangular, then it is intentionally inflicted. And the edges, we mean the wall of the ulcer at the margin. The wall could be sloping, indicating healing wound, or could be elevated, indicating malignancy. And if it is rolled in, it is a basal cell carcinoma. If it is rolled out, it is squamous cell carcinoma. If it is undermined like a cave, this occurs in tuberculosis and venous ulcer. And punch out walls or edges means it is at right angle to the floor, and it occurs in arterial ischemic ulcers and in syphilitic ulcers. By the floor, we mean the area we are looking at the bottom of the ulcer, and we find the necrotic tissue or granulation tissue. By the base, we mean the area where the ulcer sits, that is in the subcutaneous tissue. It could be indurated and thick, or it could be fixed to the underlying structures. Or the ulcer may be so small and superficial only in the epidermis. And draining lymph nodes could be inflammatory or malignant. If it is inflammatory, most likely it will be tender on palpation. Now, this diagram shows the sloping edge of the ulcer, indicating healing wound, and this is the punched out, indicating syphilitic or trophic ischemic ulcers, and undermined edges occur in venous ulcer and in tuberculosis, while elevated margins could be rolled in or rolled out like this. The rolled in could be in basal cell carcinoma, while the rolled out could be in squamous cell carcinoma. The floor is the area we are looking at the bottom of the ulcer, and the edges are the areas elevated at the margin. Now, the size of ulcer in the foot, it could be either at the bottom of the foot or at the pressure bearing areas. Ulcers of the toes are either neuropathic or ischemic ulcer, as we said before, and diabetic wounds occur at the pressure areas of the foot. The plantar ulcers most commonly seen under the hallux and big toe and on the first and fifth metatarsal heads, opposite the first and fifth metatarsal heads, or in the heel area. And the ulcers at the bottom of the sole of the foot could be either trophic ischemic ulcers or malignant ulcers. Now, squamous cell carcinoma, it is excessive in excessive exposure to ultraviolet light of the sun in the face, in the eyelids, eyebrows, and around the nose, cheek, jaw, ear, hands and feet, or trunk occurs the squamous cell carcinoma. Or it occurs at area of continuous irritation in a pre-existing ulcer, as in the Marjolin ulcer J, Marjolin ulcer of Bern. This is the ulcer with elevated margins near the nose or nasolabial fold with a necrotic edge. And in investigations, usually we take part of the ulcer as incisional biopsy, or we take the whole ulcer with the safety margin, and we call this excisional biopsy. Now, the symptoms that it could be painless nodule or scaly, and then it ulcerates. It can have raised margins, and or it looks like an edging nodule in the skin of an elderly person. It has a firm base, and it could be an unhealing ulcer in the sun-bearing areas. This is it here, here in the ear, and here in the lower lip. For staging, superficial ulcers, squamous cell carcinoma, are called carcinoma in situ, and stage 1, usually it is less than 2 centimeters in diameter and did not spread to the lymph nodes or other organs. Stage 2, it is more than 2 centimeters and also did not spread to lymph nodes or other structures. But stage 3, it has gone to the lymph nodes, draining lymph nodes, and but not to the other organs. In stage 4, the tumor has gone to the other organs. This is a very superficial in situ carcinoma. Now, the treatment, usually excisional biopsy with safety margin of about 1 centimeter around and around the ulcer. And if there are lymph nodes involved, we have to remove these lymph nodes. For superficial in situ carcinoma, squamous cell carcinoma, we can use cryosurgery, and in advanced cases, we can use radiotherapy. The 5-year survival rate for stage 1 and 2 is excellent, that is 99%. And the complication, usually, it is invasion and destruction of the adjacent structures. Now, the basal cell carcinoma, also called the rodent ulcer, because it is a local malignant invading the local tissues, usually on the face, nose, cheek, forehead, nasolabial folds, and eyelids. And it is locally invasive, and it causes disfigurement. It does not metastasize. And it increases in size and invades the deeper tissues, muscles, bone, cartilage, and may become painful and may cause bleeding like this at the inner angle of the eye. The symptoms and signs, usually it could cause some sore and or pain and red patches or pink growth and scars or grosses with raised, rolled-in edges and central depression. It may form crust or itch or bleed. Usually, no need for TNM staging. However, the depth is important because it infiltrates the deeper structures. And the prognosis of the early phases is usually good. Now we speak about melanoma. Melanoma is a dangerous malignancy, and it is due to melanocytes of the skin that grow out of control. And the changes usually start either in a mole or in a normal skin. And if it is not diagnosed early, it will spread to other organs in the body. To diagnose melanoma in the skin, usually we make a cross like this and we look at each quadrant. Usually there is asymmetry between the different quadrants, A. And B, the borders are usually irregular or uneven. And C, A, B, C, the color is usually different from one area to another area in the ulcers. And D, the diameter is usually more than 6 millimeters, and it is evolving. That is, it is increasing in size with time. This is the ABCD description of melanoma. Melanoma can appear on skin not normally exposed to the sun, like that melanoma occurring in the foot and in the nail bed. This is in the nail bed, acral melanoma, and here in the foot with satellite metastasis in the skin. Nodular melanoma is the most dangerous form of melanoma, and 50% of melanoma occurs in a pre-existing mole. Warning that any changes in a pre-existing mole, like increase in size or in shape or in color or itching or hair loss in a mole or skin lesion, might indicate a changing to malignancy, forming malignant melanoma. Melanoma spreads first to the nearby lymph nodes. Then, by blood, it spreads to the liver, lungs, bone, and brain. And the most important thing in staging of carcinoma is the depth of invasion in millimeters. The depth of invasion in millimeters. This is the skin. This is the melanoma appearing in the skin. But here is the depth of cells going to the underlying structures. The treatment for stage 0 in situ melanoma, we remove the whole lesion with at least 0.5 centimeters to 1 centimeter around and around the melanotic lesion. For stage 1, we remove at least 1 centimeter to 2 centimeters of tissue round and around the melanoma. And in stage 2, also, we remove at least 2 centimeters or more of tissues round and round the melanoma, including the depth. And newer forms of immunotherapy and target cells can be used. The prognosis for the early stages is good. For the stage 3 and 4, it is usually bad. Here are a few questions to help students' studies and discussion. What is the most common site of melanoma in an African patient? Is it the back, scalp, limbs, rectum, or face? And which of the following determines the prognosis of malignant melanoma? Is it the horizontal extension of the lesion, or the genetic mutation in the lesion, or the depth of invasion of melanoma, or presence of lymph nodes and other spread, or the ethnic group of the patient? Knowing that in dark-skinned people, usually the presence of melanin gives some resistance to development of melanoma due to exposure of the ultraviolet light of the sun. This is an OSCE question. Describes the lesion in the lower lip, and what is the most likely diagnosis here, and how could you take informed consent from the patient? This is a communication question, skills question. Here is an OSCE question that describes the lesion in the sole of the foot, and what other parts of this patient would you examine, and how would you investigate this patient, and how would you break this bad news to the patient? This is a communication skill question. And up to here, I will stop to see you in the last and fifth lecture on wound and gangrene. Leave you with good mood, great hopes. Until we see you later, I say bye-bye. See you later in good mood and in great hopes and good health.